We wanted to welcome you to the therapy sessions, and I'd like to introduce our panel of esteemed speakers we have today. Jennifer Power is DPT of Chit Chat Therapy in Rock Hill, South Carolina. Cassandra Stolting, MSCCC SLP of Chit Chat Therapy in Rock Hill, South Carolina. Jenna Lowrey, OT of Milestone Therapy in Union County, North Carolina. Katie Parsons, an occupational therapy student at Augusta University in Augusta, Georgia, and impacted by mitochondrial disease. Brenda Sorrells, OC of the Prosthetic and Orthotic Institute, Rock Hill, South Carolina. Kelvin Jones, CPO, the Prosthetic and Orthotics Institute of Rock Hill, South Carolina. And Scott Staley, ATP. And we can take it from here, Jen.
Good afternoon. Can everybody hear me in the back? Great. So my name is Dr. Jen Poirier, and I'm a PT. I've been working with people who have mitochondrial disease and dysfunction for probably longer than I would care to admit at this point. Thank you for joining us today. Hopefully we'll have a great session. What we have today is a multidisciplinary panel. We're each going to get up and talk a little bit about easy tips to conserve energy within each discipline, and then we bought lots of fun toys to come play with, and then we'll have a big question answer session. Okay, so some easy things across the board for all of us are really try to avoid stressors with scheduling. Now, sometimes you're scheduling with the provider, sometimes you're scheduling with front office staff, but if you know this is an annual appointment and you don't do well in the heat, don't schedule your annual appointment for July in Charlotte. As you know, it's really hot. So try to plan your appointments for the time of day that works well for you, and give the scheduler, you don't have to delve into the whole medical reasoning, but just, not, I don't do well in the morning, but because of my energy level and my disease process, I don't do well in the morning. We do better with afternoon appointments. Or we really try and get in first thing in the morning to avoid immune precautions. All right, and then lastly, try to have a really realistic expectation with the outcomes that you're going to be getting from us. None of us are going to treat any disease. All of us here, we treat symptoms and we work on improving functional outcomes as is. Okay, so first up, you're going to hear from Cassandra Nooner, speech-language pathologist.
Hi everyone, how's everyone doing? Oh, thank you, my clicker. All right, so like Jen said, you can call me Andy. My real name is Cassandra, but I go by Andy. I am a speech-language pathologist, and I'm just gonna give everyone a really kind of brief overview of the scope of practice of an SLP. Okay. So there are actually 9 areas of expertise that a speech-language pathologist needs to be able to evaluate and treat in order to be considered a licensed therapist. So I went through lots of schooling to be able to say that I am competent in 9 areas. So we're just going to go through each very briefly. Our voice is our ability to phonate at the level of our vocal cords. Tied in with that is our resonance, which is when that airflow from the vocal cords comes up and makes the quality of our voice as it resonates through the oral and nasal cavities. Feeding and swallowing, we're all very familiar with. Feeding is everything from preparing to eat, so scooping the food up into a bowl, getting it into our mouth, chewing it, and then when it's ready to be swallowed, our swallowing reflex is triggered. So all those muscles in our throat brings that food or liquid down into our stomach. We also are competent in auditory rehabilitation, which is managing hearing loss. So maybe fitting someone with a cochlear implant or hearing aid, and then supporting them through that journey as they learn to hear for the first time with that amplified speech. We also know a lot about alternative and augmentative communication, also known as AAC. Some of you might be familiar with that. So when a person has difficulty with verbal speech, or maybe verbal speech isn't the most efficient way for them to communicate, we can use technology to either replace their speech or just augment or enhance it. So everyone knows the most famous example of Stephen Hawking. He's a really prominent person who has used AAC in our history. All right, we're almost there. I told you, SLPs know a lot of things. All right. So now you are all speech-language pathologists. I just gave you the crash course of several areas that you need to know about. But I want to talk a little bit now about how each area might impact those with mitochondrial disease. So like Jen mentioned, we're not treating the actual disease, we're treating the salient characteristics from the disease, right? So it's going to look different from person to person. So for one person, it might be we need to work on their voice and their fluency. For others, it might be we're looking at an AAC device, right? So every person is different, and the most important thing is that you look at the area that will most impact their quality of life. So by targeting the area that's affecting them the most, how will they have the best positive outcome by us working on those things? So let's take a little bit of a closer look at how each area is kind of impacted. All right, so our respiratory system is the basis of all speech production. So if you can take one thing from me today, it's that breathing is the most important part of speech. So I want to try something with you guys today. I know I can't help myself. I want everyone to take a nice big deep breath in with me. Can you take a big deep breath and let it out? It feels good, doesn't it? Yes. Okay, very good. What I saw a little bit in the audience, and this happens without fail every time I introduce this to my clients, is I saw some shoulder movement, right? So when you think big breath in, you think raise those shoulders. That is actually a pretty inefficient way to get good airflow. What I want you to focus on this time is put your hand on your stomach, and this time when you take that breath in, I want you to think about pushing your stomach out, so pushing that hand out. Good. So that's using your whole diaphragm, your abdominal muscles. You don't have very shallow breathing up here in your clavicle and with your shoulders, but when you use that diaphragm, you can expand and get really good breath support. Another little trick of the trade I'll let you in on, if you've ever seen like a famous singer performing, a lot of the time they'll have their microphone in one hand and they'll have their hand on their stomach, and you think, oh, they're just kind of relaxing there. A speech therapist probably taught them that that's how you coordinate your breathing for singing, and they're being mindful of that. So next time you can look for that. All right. So respiration is the basis of all speech production. So the better we can breathe, the more clear and louder we're going to be able to speak. So I use a lot of breathing exercises with my patients. Sometimes people just aren't even aware of how to breathe correctly. They just have breathing patterns that they've adapted to over time, and we can kind of fine-tune those things. So with kids, what I like to do is we'll lay on the floor, and I'll put like a toy car on their stomach. I'll lay with them, and we watch our stomachs rise and fall, and it's teaching them that when they breathe in, their stomach comes out, and when they breathe out, their stomach comes in. So it's a bit of a confusing topic when you think about it, but that's why you want to practice it and get it to feel more natural. Another really fun one is putting cotton balls on a table, and you get a straw and they get a straw, and you try to race them and see who can blow the cotton ball further. You blow into the straw and blow all the cotton balls off the table. That's a really fun one. And also just blowing bubbles. You know, you wouldn't think that that's a functional activity, but blowing bubbles is really, it works on a lot of different things. Lip rounding, getting that good breath support in order to blow those bubbles. And then another one that I work on a lot is just having patients just time themselves for how long they can inhale and how long they can exhale. So if you time yourself and maybe even just once a week you try to get half a second longer on your inhale or exhale, that's a huge gain, and that's going to improve your speech over time. Wonderful. All right. So we also have our fluency and our voice and our overall speech production. So our fluency is the smoothness which with we communicate. So commonly, if you've ever heard of a stutter, that is a disruption to the fluency of someone's speech. So when we finally get that breathing under control and we've kind of targeted that optimal breathing, we can kind of go back and fine-tune some other areas that might be impacting that person. So fluency is one of those. So you can discuss, different types of fluency strategies, such as a cancellation technique, which is when you're in a moment of stuttering, learning to relax and use that breathing. It all comes back to breathing, to breathe through that moment of stuttering. I also try to use a lot of audio recordings with my patients, so just bringing their awareness to their speech. So sometimes people aren't even aware of their disfluencies, so I'll just set up a little audio recording, ask my patient, tell me about the last movie you saw, and let them speak for a few minutes, and then I'll play it back for them, and I'll kind of point out, I don't use fluent or non-fluent, I usually say, that speech was really smooth, that sounded great, that was a little bit bumpy, did you hear that? And just kind of bringing their awareness to it, so that we can learn how to use those techniques once they're aware of how their speech is sounding. Our voice also is highly tied in with our respiration. So there are a lot of vocal exercises that you can do, lots of really good resources on YouTube. If you look up vocal warm-ups for singers, it's all very connected. A really fun one that a lot of kids love doing because you tell them, like, okay, you can use your outside voice inside, is having them yell out and vowel for as long and as loud as they can. And they think it's the coolest thing because you're getting them to scream inside. Don't recommend doing that at home, just in therapy. And you can, as a therapist, will time how long that they're able to hold out that vowel sound, and I'll measure how many decibels they're yelling. So a goal in therapy is to get louder and longer, and using that good breath support that we established from the very beginning of therapy. Another fun one is using different vowel prolongations, so holding out different vowel sounds and using different pitch intonations. It's a really great way to strengthen the muscles in the throat so you can mimic those intonations in regular speech. Our speech production is our ability to use our mouth, tongue, and jaw muscles in order to articulate sounds. So the traditional articulation approach that you might think will be listening to someone's speech and thinking, oh, that maybe the child's using a W for an L, or maybe they have a lisp, and we go through and target those individual sounds. But for this population, what we really want to think about is making sure that we have precise articulation and enunciation. So something I do with a lot of my kids is I'll print out what's called a pacing board. So I'll ask them like what their favorite movie character is, and let's say it's Sonic the Hedgehog. I'll print out just a document with 5 pictures of Sonic the Hedgehog, and we teach them to touch Sonic for each word they say. So for example, I say, okay, we're gonna say, I like to play baseball. And it's teaching them to use that breathing that we worked really hard on and coordinate using that breath support in the middle of a sentence. So it just naturally slows them down and brings their awareness to using that pacing board to increase their overall communication. Very good. All right, feeding and swallowing, everyone's favorite topic. So if the client is willing and able to work on feeding, that's definitely an area that SLPs work on. But however, we do it with a multidisciplinary team. So this is an area of speech-language pathology where we really value other people's opinions. So we might work with a radiologist to do a modified barium swallow study test. We might work with a GI doctor to determine what diet and consistencies work for this patient. We might work with a nutritionist to determine how many calories this person should be inputting. And our wonderful OTs and PTs we work with to make sure that they might need adaptive equipment, so like a weighted spoon or a bowl that can help them scoop and bring food to their mouth. For PT, big thing with feeding is posture, so making sure that they're in an upright position, their feet are supported. Because again, going back to that respiration, if you're hunched over or if you're sliding forward in your chair, your belly isn't able to expand to use that abdominal breathing. And it's like a domino effect. It affects every other part of your speech, including your feeding and swallowing. Okay. Okay, I got it. Alternative and augmentative communication. This is one of my favorite areas to work with. It's basically, like I said, a type of communication that if a person is unable to speak verbally or if that's too cumbersome for them, we can supplement their speech or even replace it with technology. So it kind of falls into two camps, and we have lots of examples over here that you can look at later, and I'll happy to answer any questions and explain. We have our low-tech devices, which is anything from like a picture card or a switch, like a single-cell switch, or even just having a person write on a whiteboard would be a great example of an alternative communication. And then we also have our high-tech, which is kind of what people think of most when they think of AAC, and that's our dedicated speech-generating devices, eye gaze technology, things of that nature. Okay, so AAC is really cool and very innovative, but the point I really want to drive home is it can be life-saving for many patients. So if there's an emergency and the child knows all I have to do is press this button and it tells the EMT my name, my address, my phone number, and my mom's name, that can be life-saving. You can also use it in a hospital to tell doctors, where your pain is or what your pain level is. So it's huge, and I try to start my patients with AAC as early as I possibly can. Another point that I just want to drive home is there are no prerequisite skills for AAC. So what I mean by that is you might hear some professionals say, if I bring up, okay, let's maybe start an AAC device, professionals might say, well, they need to be able to point first, or they need to be able to attend to a screen first, or let's try picture cards first. There is no prerequisite skill for AAC, so that means anyone with any ability level can find a device that works for them and helps them in their daily life. So it is our job as speech-language pathologists to help you find a communication system that works for you and to advocate for you, because a lot of professionals are not really on board with AAC yet. So I'll get off my soapbox now about that. All right, so a lot of people ask me, how do I go about getting a communication device? So the first thing you want to do is you can go on to the American Speech Hearing Association.org. It's ASHA.org, and there's a list of AAC practitioners in your area. You can search by city and state, and you can find a licensed speech-language pathologist who can do AAC evaluations. And that might look like different companies attending and giving you trials with each device and seeing kind of what works best for you. And then another wonderful program that is in the state of South Carolina is called Amplify Life. And what that does is as a speech-language pathologist can request a dedicated speech-generating device for any client with a diagnosis. So it can be even just a diagnosis of a speech and language delay. This South Carolina government program is wonderful, and we can get a free iPad for anyone who has a designated diagnosis. So that is another wonderful resource for you all. All right, so in conclusion, there's a lot that speech-language pathologists do. I always get asked, so what do you do? Don't you just fix lisps all day? And that could not be further from the truth. So thank you for listening to me. Again, I just want to drive home the point that therapy should be functional. So if you go to a speech therapist and you're like, yeah, I really want to work on my breath support, I'm running out of my breath mid-sentence, and the therapist says, well, let's try working on your S sound. You might want to reassess, is this really the right fit for me? Because it's so important to have that right fit with your therapist and making sure that they understand what areas impact your life. Lastly, therapy should be functional, but it should also always be fun. So make sure that you have the right fit of a therapist for you. Thank you so much. Oh, yes. We're going to take questions at the end. So hold it for me, and I'll get to you. Thank you.
Get a little tutorial real quick. Hello all, my name is Jenna Lowrey. I'm an occupational therapist, and this is Katie.
Yes, I'm an occupational therapy student at Augusta University.
Yes, so she brings us an additional perspective. So occupational therapy, if you go to ask my dad right now, what do I do for work? He has no idea. And so I often tell people it stands for the other therapy, because physical therapy is straightforward and speech therapy is straightforward, and OT touches everything in between physical therapy, speech therapy, and coordinates with everything that they do at the same time. So you'll see there's a long list of areas that are covered under occupational therapy, and I'm just going to go through each of them and kind of let you know how we can help to support clients through energy conservation techniques, different assistive devices, different low-tech, high-tech tools, pretty similarly. So I typically work with small children, so you guys are all very tall to me. And I'm also used to sitting on the floor talking to people. Okay, so ADLs stands for Activities of Daily Living, and IADL stands for Instrumental Activities of Daily Living. So some of these activities are dressing, bathing, toileting, grooming, meal preparation, housework, and driving. Every single one of those things requires energy, and it requires sufficient energy to be able to perform it yourself. As an adult, you don't have a caregiver to help support you all of the time. You may have a family member or whatever type of staff you might need to support your needs. Children have caregivers to help to support them through. And even in that, we meet individuals, whether it be a child or an adult, where they are based on their skills and abilities. And so that might be whereas when I'm looking at clients and I say to the parent, I say, well, what do you want for us to work on? How can we help support you? So I have some 3-year-olds that can benefit from building independence and putting their shirt on, but if the parent doesn't care about them putting their shirt on at that time, then that might not be the priority that we select. It doesn't mean that we don't work on upper body strengthening to build those foundational skills, but what the client's priorities are, and for a child, the parent has input on those, that's what the priority in therapists, or in the therapy treatment would be. Just like Andy alluded to, you kind of have to have your therapist, I always say you have to vibe together. So you and your client have to kind of gel together and have that relationship, so that way you kind of foresee where each one is going. So some of the things that we can utilize to help support us in the ADLs and the IADLs would be use of adaptive devices such as a sock aid, a reacher to pick up clothes. It could be shoestrings that don't require tying. There's so many low-tech things that you can find, and now you can find them at Target or Walmart, versus we used to have to go through like therapy magazines to find them. And we also have a great resource in our up-and-coming therapists that are far more creative than I could be in creating things. And so I'm actually going to let Katie talk about something that she has created, her own very own assistive device.
So my mom is a cane user, and she utilizes the strap on her hand so it doesn't fall. And I noticed, like, if we're out and at the grocery store, it's a hassle to have to take it off and then set it down because it's going to fall. And then if you keep it on, it's hitting against the counters and at the grocery store. So I put a retractable hook on it so that you can just keep it near you. So like you can still reach up and do things, and yeah.
And what kind of hook did you use for it?
It was a keychain I found on Amazon. So
You should patent that.
Yes.
that's what I've been told. So we're working on it.
So no invention is not worth it. Every invention works for somebody. So we had to come up with things in school, but I don't think mine was ever as cool as that. And I don't think anyone ever used it afterwards. So our next area would be our fine motor skills, and I always tell people they're like our cute muscles. So our fine motor skills are our smaller muscle skills, whereas PT and OT as well, but we address those gross motor skills. So that's like your gross movements. I'd say they're ugly. They're not as cute. So these would include like brushing your teeth, facilitating your clothing fasteners, manipulations that require dexterity. So that would be pressing this button each time, making sure I have the correct one, not having to look at it, but knowing where the button is. That awareness is part of your fine motor skills and sensory combined. I keep hearing that, okay. But it can also be something like you reach into your pocket and you have to pull some change out. You know, you have your keys and you have to shift it in your hand to be able to open your door. So all of those are daily skills that we utilize and also part of your fine motor system. Some activity or some things that we can utilize to help support that with energy conservation would be for the kiddos or even for adults with handwriting or even typing is using a slant board. I said I've officially given in and I now have like an incline board on my desk for my laptop so that I can be in a more, a less intense posture for my wrist, because when you're here, you're constantly contracting and it's not good over time. Hence carpal tunnel in individuals that work, that do a lot of computer type work. So if your wrist is in a more functional position through something as simple as a slant board that I also got on Amazon, then that $30 investment is saving you from having to get a wrist splint down the line, having to have an orthopedic consult, having to maybe have a surgery, something as simple as an incline, and that works the same for children. Is this ringing or is something else ringing? Okay, it's not this, sorry. And so for children, we would use an incline slant board, and some of those are adjustable, whereas you can adjust how high it would go, and some of them are just basic pieces of plastic that are formed. I also go way low with it, and I just tell parents to buy a 3-inch binder and put a piece of non-slip on it, and boom, for $6 versus Amazon, which you could still get on Amazon. Then you have your slant board, and that helps kids to, again, alleviate that positioning, and it puts them into a better posture for their wrist, so that way they're not overworking the muscles that should be resting, and they're utilizing the accurate muscles. You can also look at alternative writing devices. So they have like large pencils, they have some adapted pencils, they have pencil grips. I'm not usually a huge fan because the kids tend to just grab around the pencil grasp. But there are a variety of alternative writing utensils, or you can go to typing as well. In addition, you can utilize an AAC device, and oftentimes the AAC device can be used for that written expression piece, as well as using a lot of times like a PECS type picture communication system. So as far as like brushing your teeth or using utensils, you can use a built-up handle, and the built-up handle can be anything from like an actual utensil that you can purchase that's like a large knob utensil. It might be like this big around, because this grasp is going to be easier and require less energy than this fine motor, more finger manipulated grasp would utilize. And for that, you can use something even as simple as like PVC piping. So you can just get that and fit some Play-Doh in there and shove your spoon or fork in there, and then it stays, and then you use that built-up handle. So we try to keep it as Home Depot level, as Walmart level as we can, because so many times we're trying these different things and one might work for one but may not work for another. So I hate to have people make a large investment for it to not necessarily be just the right fit for them. I think I already touched on like the no-tie shoestrings. You can utilize zippers as opposed to buttons. And then also for scissors, they have adapted scissor options. So they have what's called like a spring-loaded scissor, whereas the patient just has to close to squeeze, but it'll automatically open. So it'll automatically facilitate that. So again, you're conserving energy because they're only having to exert half of the energy for the task. As far as the next area is your visual motor integration. So that's a combination of your motor system, which is the movement, and then your visual system, which would be your eyes, and coordinating them together. The simplest way to put that is your hand-eye coordination. And so with this, it would be some, again, adaptations that you can utilize to help support would be using a slant board to support your upper extremities and also to reinforce your posture optimally. So that can help support for handwriting, for drawing, for puzzles, pretty much anything on there, just as far as it has a target. And then for written expression, it would be typing or handwriting. Those are all part of your visual motor integration system. With some kids, some therapists want to get their writing to be like, I guess, quote, socially appropriate. For kiddos, I am typically a little bit more flexible, whereas, even if your letters are 1 inch tall, your letters are legible, you have the confidence that you can produce those letters, and they also get the success of being able to write their name or whatever it is that they're writing. Even if it may be large, they've done it on their own, so they get that sense of achievement. As far as drawing, some things that you can do are to utilize a variety of mediums. So you can use finger paints, you can use just about anything. You can use a paintbrush, you can use different things, you can use larger tools. So that way, the individual isn't just locked into using a pencil or using a pen. And then we have this really fun area that makes us the other therapy, I feel like, is sensory integration, because it can be a whole presentation of itself. So I tried to condense it a lot. So as far as the areas I felt that would target the diagnosis and energy conservation, I feel that self-regulation, that skill of being able to increase your self-awareness, to take those deep breaths, to say, when you start to get a little bit worked up, that's supremely important, especially as an individual gets older. Sometimes for the small children, that's our job as parents and therapists, is to help coach them so they build those skills, so that when they get to school age and when they get to teenagers, they can self-advocate and they can express for themselves, I need to take a break right now. It's just a little bit too much. So then as far as our typical sensory systems, our touch, taste, visual, auditory, and smell, those are the 5 senses that we learn in school. So as far as those, sometimes individuals' irritability can affect their tolerance of a variety of sensory input. And so if somebody is at a higher, level of irritation, or then they may be less tolerant to a buzzing noise that's in the background or something of that sort. So helping them to learn how to balance that out. And then our invisible senses, as I call them, would be your vestibular system and your proprioceptive system. Now, we learned in school that these are the systems that teach you where you are. They are your body awareness. They're primarily located within your joints, so you benefit from those weight-bearing activities, from the pounding input, from even just walking. You get that input through your lower extremities. So as far as these levels, or these sensory inputs, something that can sometimes help support are like compression clothing. And again, it depends on the individual, but compression clothing can help to give the body a consistent sensory input to help know where you are. So if your body knows where it is in space, you might be less likely to trip over a stair. You might be less likely to trip over nothing. You know, it just helps your body to be able to flow through the environment. Some things that we can utilize to help support would be environmental modifications. So something as simple as a dimmer switch within your bedroom, or dimmer switches throughout your house, or maybe lighting at certain levels that help based on your eyes. So based on where your eyes are most receptive, some lights in that way. And then also noise canceling headphones. Those are really good for the kiddos, even in the classrooms, and just normalizing that. You know, they have cute ones, just like when you see more babies with helmets on these days. You know, they create everything is cute now. So it's really great because it becomes less socially awkward, so to say. You're not like feeling like everyone's looking at you because you have something that's unique. Now it's more common, and individuals, whether they do or don't have sensory challenges, you know, are given the option to utilize such things. I have the typical kids in the classrooms that more often are using the tools than the kids that have sensory challenges. I think I touched on that. Is that the last one? So the next area is functional mobility. Now, functional mobility would overlap a lot with physical therapy, and also down the line, most likely with Scott and Brenda. So this is an area that really requires, just like Andy mentioned, really requires a cohesive team to be able to create that support. So functional mobility would include bed mobility, so that would be mobility within the bed, as well as getting into the bed, getting out of the bed. Transfers, which would be getting from your bed to your chair, if you may use one, getting from your chair to a toilet seat, things of that sort. And then also community mobility, which would be getting through your community. So that might be walking, that might be rolling, that might be using a walker, even your vehicle. You know, those are adaptable so that we can make that the right fit, and OT can have a part in that. So some of the things that we can utilize here would be like bed rails. Again, you can utilize a reacher if you need to grab your socks. Some people, it is easier to get dressed when they're in the bed because it's just one less transfer to exert your energy levels. So utilizing maybe your sock aid or things of that sort really help to preserve some of your energy levels. Executive functioning, this area would overlap again with speech therapy because we both are addressing the cognitive aspects and a lot of times working on sequencing. Now we may look at it from two different perspectives, but we are working towards creating those same skills and solidifying those same skills. So whereas I may be looking at problem solving so that we can sequence an ADL routine, speech may be looking at problem solving from the same and then also reinforcing utilizing more communication. So some adaptations that we can use here would be visual cues, and that could be like a visual schedule, whereas a child has a picture schedule and they can have a to-do and a done, and they can switch it from to-do to done, to-do to done, to-do to done, and then they know when they've completed all the tasks of their routine. So it helps in that memory aspect as well. That's what the sequencing leads to. And then in general, with your environment, it's much easier to scan or to find something if your environment is organized. My teenager doesn't believe this to be true, but it is true. So in a more visually organized environment, then you're able to find what you're looking for, or you're able to look through in a way that you're not going to have to go through every single drawer to find what you're looking for if you know kind of how it's organized. And then a big one would be mental health, of course. Now here you would most likely benefit from some type of a true mental health counselor at times, but we also know that sometimes, you know, you go through phases where you might use a counselor, and then sometimes you might be able to support in alternative ways as well. So ways that your mental health can be affected or that OT can help support would be improving your focus. We can do that through sensory input. We can do that through different prompting or, you know, teaching skills, utilizing like a metronome as far as that auditory. And then also understanding self-regulation. Like I said before, if you understand the things that help your body to stay calm and you understand the things that ramp your body up, then you can advocate for yourself to say, I just can't do that today. And then to not feel bad about that. Like I tell people, no is a full sentence. No, period. You don't necessarily have to explain. A way that we can also help to increase that self-actualization and those regulation skills are through social stories. And here again, we overlap with speech therapy, whereas we can utilize social stories, especially for the young children, because that's how kids learn. They learn through play. So whether it be like a therapeutic type of play where we're pretending with the little people dolls, or whether it's looking through a story that is, hey, remember that time we went to Carowinds, and it kind of goes through how did we do while we were waiting in the lines? What was the hard things? What were the easy things? And what helped us get through the hard things? And then lastly, we have coordination, which would be like your motor coordination. And here is where we would overlap with physical therapy. I say overlap, maybe double support. Maybe that's better, because we all support each other here. And so this would be just coordinating the two sides of the body, having that sensory side also for that body awareness, so that you do know this is your right side, this is your left side, using them together. And also coordinating your arms and your legs to work together. So there's different tasks where your arms work together to do the same thing, like if you're throwing a ball, they're doing the same exact thing. And then there's other tasks like buttoning a zipper or zipping up a zipper, whereas one would stabilize and the other would zip up. So there's tasks where they work together and tasks where they work together but have separate jobs. So building on those skills as well. So some things here we would utilize would be our manual therapies can help a lot here, so whether it be gentle massage, using passive range of motion, just kind of helping to stretch the muscles so that way they're getting everything that they need to get. And so here we would also focus more on the quality of movements versus like the number of repetitions you're able to do. So if an individual can do 3 solid repetitions with really great quality of movement, but then after that, the quality of movement declines, then it's not as beneficial. So we should just stick with the 3 repetitions where we have that high quality of movement and then gradually work up from there. Thank you.
Okay, so next up we have physical therapy, and when I meet a patient for the first time, I'm looking at a few different things. I'm looking at their pain level, their range of motion, their ability to balance in multiple positions, their strength, their functional mobility skills, gait if they have the ability, and posture in multiple positions. Pain is something that I find I'm often addressing in this population because pain is fatiguing. Pain is fatiguing. So if that is often the first thing that I'm addressing in this population, because if we can minimize pain, then we can kind of stop that fatigue cycle and work on moving in the positive direction. And all of us here are working on conservative measures, right? We do things outside the body. We don't do things inside the body. We don't put things inside the body. So things that we can use, conservative measures for pain, obviously heat or ice, depending on the type of pain, and then electrical stimulation. We can use gentle movements. I often tell my patients motion is lotion. Gentle movements help to lubricate the joint, and that will help to alleviate pain in the joint. I do a lot with kinesiology taping. That can help with inflammation, it can help with pain, it can help support the joint or the muscle. And then like Jenna was saying, manual therapy. You can do massage, and there's different types of massage that you would use for pain, for swelling. And another big one that there's a lot of studies coming out now is vibration therapy. When I'm in the clinic, I have a vibrating platform that I'll put kids and adults on, and then you can do pinpoint vibration for inflammation and swelling at the muscle level. Range of motion. Oh, sorry. Okay, range of motion. I consider myself to be a more function-based PT, and I am 100% willing to sacrifice a few degrees of range of motion to get a better functional outcome for the patient. So when I'm reaching up high, now I'm short, so I do have to reach up high, but most times you can reach at 160, 150 degrees the same as you can at 180 degrees. So why waste the energy trying to get those last couple degrees if we're functional here? One thing that I use a lot in my patients is working on improving range of motion 24 hours a day. So what that looks like is adapting how we're sleeping to facilitate a more midline positioning that will have carryover during the day. There's a really, really fantastic course. It's called 24-Hour Positioning. Fantastic. But really what we've seen over time is improved daytime positioning and outcomes in patients where we can slowly change range of motion overnight. Okay. Balance. There was a lot of talk about balance earlier today for anyone that was in those sessions. Really super fantastic things coming out about new balance measures. But really the first step I find is figure out what is the cause of the balance deficit. Sometimes it's vision, sometimes it's proprioception, sometimes, it's a muscle imbalance. And once you identify the cause of the balance deficit, is it a problem with static balance, standing still or sitting still, or is it a problem once we reach that dynamic? Like I can sit perfectly still, but then when I reach to get something off the shelf, that's when I lose it and can't come back. So figure out where the deficits lie, and then we start where the patient is from there. Strengthening, that's what you mostly think of when you think of PT. And we do a lot of strengthening, but when we are strengthening, like Jenna was saying, we want quality versus quantity. So if you think about the ways that you can strengthen a muscle, you automatically think like, okay, we're at the gym, we're using weights, we're using the bands, but sometimes a patient can't lift up against gravity. Right? If we're working on strengthening our bicep, we can't do a bicep curl against gravity, some patients. So what we can do is take gravity out of the equation and put them in an anti-gravity position, and still work on strengthening that bicep and those muscles, whatever the muscle might be, in a functional manner for the patient, and then gradually get to anti-gravity movements. We're still strengthening the same muscle, it's still getting the same benefit, but sometimes we just need to meet the patient where they're at. Functional mobility skills, there's a lot of overlap between all of us in this. I think Jenna touched on this beautifully, and anyone that has questions on this later, we are more than welcome to answer as a team. But one thing I want to add is another functional mobility skill that we all want to start addressing, or not start, but another one that we are addressing is not only can they stand, can they transfer, but how long can we stand? Can we stand to brush our teeth? Can we stand to cook a meal? Can we stand to do all the dishes? Or can we only stand to do one of those? And if we can't, then how do we supplement that with some supports? Gait is walking. So some of our patients are ambulatory and we're working on gait, and some aren't. But for the ones that we are working on gait, we're working on, again, quality over quantity, making sure that the gait is efficient, and then slowly improving endurance to improve overall cardiovascular health. So sometimes it's a flexibility issue with range of motion, and we need to address making sure they can get their hip into extension to have a more fluid and efficient gait. Our goal for optimal cardiovascular carryover for walking is 20 minutes of cardiovascular activity a day. Now, most of my patients cannot do 20 minutes of cardiovascular activity a day. So sometimes I'm starting with 30 seconds, and then we're doing 30 seconds twice a day, not 1 minute, but 30 seconds. You just have to start where they are at, and we can always make positive changes as long as you're setting realistic expectations. Posture. Our goal in this population is always going to be to work, but without overtaxing, because then we start running into negative outcomes. Improving posture into a more midline positioning can help with respiration, like Andy talked on, can help with GI, and it helps with pain because you're minimizing stress on all the rest of the joints throughout the body. So our goal in any position, whether it be laying down, sitting up, standing, is always to get into as close to midline and neutral as we can. For individuals that are seated for a majority of the day, they have either they're a wheelchair user or they are, a desk worker. I don't know how to say that. Somebody that works at a computer all day, right? Like, we're looking at our posture throughout our day. So what small changes can we make throughout the day to get into that nice midline positioning? All right. So we also want to make sure when we are doing any kind of activity that we are making sure that our body is ready for the activity. And that means that we are getting adequate nutrition and hydration. Now, there oftentimes are a lot of comorbidities in this population with dysautonomia or POTS or, lots of things. So we want to make sure, especially during these warm Carolina summer months, that we are adequately hydrated so that our body is able to support the activity that we're doing. There are times when our body needs different levels of intake, like if we're healing from some kind of physical trauma. In order to heal, our body needs extra protein in order to rebuild cells and muscle. All right, so we're going to head into some of the more fun things, I think, that come with my job is assistive technology and bracing. I just want to kind of note before we go into here, this is one thing that I throw to my patients a lot when we're kind of in that transitional, like, do we need a device, do we not need a device? It's kind of scary to think about at first. I don't know how many of you are local or how many came in from out of town, but we have a very big amusement park. Here, you probably saw it on your way in, Carowinds. And when kids are kind of on the border, like, I think they might need a device, but they're not ready or their parents aren't ready, I always ask them, how do you navigate Carowinds? And it's usually met with, well, I don't, because I can't. And so I pose the question usually, well, if you could ride throughout the park, would you have enough energy to get off and ride the rides? And that usually is an easy way to kind of bring up the big, scary wheelchair word, because really it's a tool that we can use to improve mobility skills. Okay, with that, mobility.
Hi, I'm Scott Staley, and I'm an assistive technology practitioner. So people are probably like, well, what's that? So that's a certificate that you can get if you provide equipment for individuals. Now, also speech therapists may get it, and other physical therapists may get it as well. But basically, we come in, and we're the kind of the go-between between insurance companies and the family, the client, and also the therapist, or what you may want to get. okay? So we help you navigate the insurance, which is always really fun to deal with. I hope nobody here works for the insurance companies, so I kind of throw them underneath the bus. But anyways, so basically I want to kind of talk about the evaluation at first. So the evaluation can be anything type of equipment that you feel like the individual will need. So it could be where the speech therapist talks to me about something, because some people we will do some of the assistive technology stuff. Maybe it's the OT that comes in and says we need some bath equipment, or it could be an activity chair, and then also physical therapy may come in and talk about standards, wheelchairs. So it's really good to have like a team effect. So if the client needs a piece of equipment, make sure that one of those therapists is there along with the wheelchair guy or wheelchair female. All right, make sure they're there so they can be your advocate to make sure you get the right piece of equipment. Right? And from that standpoint, so you can kind of talk about, well, this is kind of what we're looking for. This is what our home environment's like. But then the therapist can come in and say, but this is really what we need the positioning to be, or this is what our functional goal is going to be. And by that, then they can kind of all put that together and make sure it works out for the individuals. All right? If it ever went through the equipment process, it can be a lengthy process. So basically what happens is you figure out that evaluation, you figure out what you need, and then the therapist gets to write a letter of medical necessity. Now, they love to write those letters, so you should have them write as many as possible, all right? Because they're usually a couple pages long, and what you're going to do from that point is they're going to take that, the provider's going to take that along with some of the information from the doctor, and they're going to submit that to the insurance companies. Now, I can't speak for all your states, but the state of North Carolina loves to come back and ask more questions. And if they would have read the letter of medical necessity, they may have found that, but sometimes they don't. So then the therapist has to write an addendum to it. And sometimes a third. And so once all that does, most of the time it gets approved, and the equipment will be ordered, and then it comes in. Once again, make sure your therapist is involved in the delivery. Because and I'm going to show you in a minute on a wheelchair, there's so many different things that can make the chair perform a lot better than typically just out of the box. And obviously you want to make sure, excuse me, I'm losing my voice today. You want to make sure that it is well set up well for them so they can function as well as they possibly can so they don't get tired throughout the day. Okay? So I kind of want to go into that and kind of talk about manual wheelchairs. Now I'm going to kind of be walking around, so I apologize. I'm not going to have the microphone right here, so hopefully y'all can hear me from that standpoint. Thank you. Hold on one second. My asthma does not like this hot weather sometimes. All right, so this is one of the manual wheelchairs. All right, now this is what's called a rigid wheelchair, and then there's a big difference between rigid wheelchairs and folding wheelchairs. Now everybody's probably seen a folding wheelchair, correct? Just kind of folds right up. A lot of times when people look at rigid chairs, they will get nervous thinking, oh, I can't transport that, or that's really for the athletes, the guys that are real young, they're jumping off curbs and stuff. And that's not necessarily true. Rigid chairs will decrease the weight a lot, probably by at least 5 or 6 pounds. There's going to be all these different frames out there. There's carbon nowadays, there's titanium, there's aluminum. So depending on what you get, they're going to be set up from that, all right? They still will fold down into a box, so you still can transport it. But one of the nice things about rigid chairs, because it is rigid, let me take my little smart drive off here. Because it is rigid, it doesn't have that folding cross brace in there. All right? When you have that folding cross brace over time, it's going to start wearing out. And so as you try to propel the chair, you lose some of that propulsion within that folding frame moving back and forth, and it doesn't come as efficient to propel the chair. All right? So having a nice lightweight chair is really important from that standpoint. The other thing that you can kind of look at is set up is depending on the individual and what all they need, some of the things Jen talked about from a positioning standpoint, you can get within the wheelchair. Now there's a ton of that kind of stuff out there, but I just want to kind of hit like how important it is. So for example, the cushion. All right, having a really good cushion there will give you that support you need. So if you have the right positioning of the pelvis and the support, then it's going to allow them to stay upright. So it will help out in all your daily needs. So for example, if you're going to start using your hands for stuff, or you're working on a computer, having that stability here allows it to go all up. So make sure they get a really good cushion that they can use throughout the day. Back supports are really nice too. Typically they come with sling upholsteries. Sling upholstery is lighter in weight, and sometimes that's all people need. But with a solid back support, the same thing. It will give them that support, allow them to sit upright. If they start getting weak throughout the day with their trunk, then it's going to help them stay upright from that standpoint. Make sense so far? All right. So one of the other things that's important is all the higher end wheelchairs, the lightweight wheelchairs, have the ability to move the wheels forward. All right. So this is really important from that standpoint, from access to the wheel. So same thing, if the individual is getting tired throughout the day, then having that wheel coming forward allows them to get better stroke propulsion. So by example, what I mean, and let's just, because that chair is kind of one of my demos, so it's kind of set up for me. So let's just play around and say it's not. Typically when this comes from the factory, the wheel here is going to be about right here, if you look at this axle. So by chance, if I was pushing it, then I'm kind of getting right here on the wheel, and this becomes my stroke propulsion. So it takes me a lot more to go throughout the day. So it's going to tire me out more. It's going to hurt my shoulders throughout the day. If you can get that wheel closer up underneath them, then they get better propulsion from that standpoint. They become a lot more efficient. You're not using that body as much to help propel yourself around. All right? So that's really nice from that standpoint. So making sure the chair is set up appropriate for the individual is really important from there. Sorry, forgot to. So the same thing as far as with the front casters, the little wheels. Same from that standpoint too. You kind of want to look at that, because if you have too much weight on the front of those casters, same thing. It makes it a lot harder for the individual to propel the chair. So if you have somebody that, or yourself, that's trying to push a chair and it really becomes difficult, a lot of times look at those wheels. So the same thing. If this chair wasn't set up right for me, and I was here, more of my weight's on those front casters, it makes it harder. It makes it harder to go through things, makes it harder to get up over ramps, stuff like that. So having that placement is super important from that standpoint, and how the casters will help you with the wheelchair. All right. And when I talked about rigid chairs earlier, you may have somebody that's 15 years old and they're going to start driving soon. The rigid chairs work well for them if they're going to be driving themselves. All right? So for example, you can take this chair apart. And then it's a lot easier if you're sitting in the car to be able to pick this up. And this is typically what a lot of people do. They'll wrap it around between them and the steering wheel, because you can recline your backs back, and they can put it beside them. So they can be a lot more functional, be able to get out and about a lot better, and still be able to transport it. Okay? So as your kids get older, or somebody else that needs a chair, that's where rigid is nice. All the ATPs have access to samples. So if you really feel like, hey, I need to kind of look at my environment to make sure it's going to work right, they can usually get several different samples to let you try to make sure. Now, obviously, it's usually just that while you're at that appointment, but you could take it out to your car. Can I get this into my car? Can I do different things? So it'll be very close to your size that the individual needs. So that's kind of a nice thing from that standpoint. All right, let me get this back together real quick. The other thing, too, is the rear wheel. All right, so the rear wheel is really important. We talked about bringing it forward, but also the weight of it. All right, now a lot of times in evaluations, they'll start talking about the wheel and they will say, do you want a pneumatic tire? That's air. It may lose some air, may get flat, or you can get a solid tire and there's no maintenance. So if I ever hear no maintenance with my car, I'd be like, yeah, sign me up, right? So that's the problem though, is that with solid tires, they add about 4 pounds to your chair. So that's 4 more pounds that you're trying to push all day long, and it makes it a lot harder to get around. So yes, you do have to blow up the pneumatic tires. They are sometimes a little bit of a pain, but if you ever pumped up bicycle tires, there's no difference. So it does decrease the weight. It also acts as a shock absorber for the chair, so they don't feel as many vibrations. So that's a nice thing from that standpoint. Now, also it has spoked wheels. And I apologize, the company I represent now does not have what they call mag wheels. So a mag wheel is a black plastic wheel that has big spokes. Same thing, it adds a lot of weight. And a lot of people will go back to, you can have a mag wheel, especially if you're going to school, and you don't have to worry about it, or you can get spokes, and they may break. I think I've been in this industry a really long time these days because I'm getting older, and I've had to repair like 3 or 4 wheels for spokes. And usually I would go down to the bike shop and say, hey, can you fix this spoke for me, and I'll pay you $5. And it's a lot faster than me trying to do it myself. And so typically spoke wheels don't really break as much unless you just have some of these young kids, especially guys, that have a tendency to jump off loading docks like I've seen before with their wheelchairs. And so then they might start wearing them out. So, you know, typically you look at those type of things and don't just go, well, it's a lot easier for you to maintain, because then you're just adding like 5 to 6 pounds to the chair. And think about all day long, if we're walking around, adding another 5 pounds to our back as we walk all day long, okay? So that's my soapbox for wheels. All right, so I also want to talk about the Smart Drive. The big name of it is called Power Assist. So, thank you, Jen. So, Power Assists are really nice. So it'll actually take a manual chair and allow that to have some sort of a motor on there to be able to then propel. So same thing, you may have a client that can push around their home really well and maybe certain areas, but maybe they still go to work and they're going to be going long distances, or they do want to go to Carowinds from that standpoint, and it just is a lot harder. Or the kid that's in elementary school is now going to high school, and high schools are super big these days. So the Power Assist will allow the chair to help them. Now, once again, like I said, there's 3 different types out there in the market. There's another one like ours, and then there's a different version where the wheel has a motor in it, and the harder you push the hand rims, and then it'll go for propulsion. Now, it depends on the individual. Some are better for certain people than others. So even though my company does the Smart Drive, and y'all should always just use the Smart Drive, there are other ones out there that may work better for you. So you may want to at least look at those and see what's best for the individual. All right? So, for instance, what this is going to do is I have a little speed dial here on the side, and I'm going to turn it on so you can actually turn it and it starts moving. So then I can just move my hands back and forth on what I want to do, but it allows me then to walk along with my friends and stay at speed without getting tired. So that's a really nice option for people to be able to get. The same thing, it's small. You don't have to try to get a vehicle to try to transport it in like a van or anything. And you can use it when you want to, and then you can remove it and not have it. The unit weighs about 11 pounds, 11 to 12 pounds. It'll go all day long, and it just charges with a battery. So it's a really nice option for you to look at. Even if you're getting a manual chair and they're starting to get tired throughout the day, then this will give them that ability to use it. Now, I will tell you that insurance companies will, especially in some states, North Carolina, will fight you tooth and nail to try to get one. They would rather you go to a power chair, which is crazy, we all know, if you don't need the power chair. But they will fight you for that. So you have to kind of use your addendums like we talked about and try to get it covered. If they won't pay for it and you get a denial, there are foundations and other charities that will help pay for a lot of those. So once you get the denial, don't just stop. Kind of research that. I know Jen has a lot of different different grants and foundations. Like even our company, Permbill, has the Permbill Foundation, which is a separate nonprofit, and they will pay sometimes up to 50% of things like that, even if it's not our product. Okay? So there are different things to kind of look at to try to help get that covered, even if it doesn't get covered.
But a lot of times you need the denial first.
Yes, you definitely need a denial first with most of the grants, because they're going to want to make sure you've went the route to try to get that denial from that standpoint. And even if you do get a denial with your insurance companies, you do have the right to appeal. And it's you against them at that point, and you can kind of plead your case. And so I have heard people that have gotten them covered once they kind of hear the situation. So power. So Jen's actually going to help me out with this one.
So usually this is a team approach when we get to the point where we're talking about adding any kind of wheelchair, whether it be manual or power. It's going to be either the PT or the OT, sometimes both, and an ATP working together on this.
So we could just kind of go over the power first. There's lots of different things you can do with power chairs. So there's front wheel drives, which is what this one is. There's also a mid wheel drive, which is your drive wheels right underneath you. There's pros and cons of both of them. So same thing, kind of ask those questions. If somebody comes in and goes, well, you just need this, I would get nervous because you kind of need to look at your environment. If you live out in the rural area, sometimes a front wheel drive works better because it's going to help you climb over things. All right, it does better in some tight turns, but you also can do a mid-wheel drive, which works better in other environments, maybe a lot of turning spaces. So somebody works in an office and they need to be able to turn around really tight. Sometimes the mid-wheel drives work better from that standpoint. So it's kind of nice to be able to have options to look at and make sure it works well for them. Yes, ma'am.
We just got a power assist chair for my son, and we were able to demo it. We worked with his PT and the equipment vendor at school, and he was able to demo it with a school-based PT for about 2 weeks in
Right.
the school building.
Mm-hmm.
So I just wanted to throw out also, like, if you're thinking about it for your child or for yourself,
Try it.
and you're working with a PT, ATP, or whatever, and a vendor, you might be able to trial it in the environment you're using it in.
And that's really good to be able to trial it for multiple reasons. But one of the things for insurance companies, for your therapist standpoint, then they can kind of talk about, for my manual chair set up in this configuration, I can push 100 feet and it takes me X amount of time. Sorry. I've never talked in front of a microphone. So I can do, push 100 feet within a certain amount of time. And this may be what happens to my saturation, or this is how tired I am. And then you can kind of have all that in your letter. And then you can say, well, I used a power assist. I can get down at the same, 100 feet within this time. And this is where I can use it. And so that's really nice to be able to do that. A lot of times you can borrow it for a couple weeks and typically use it and trial it, especially like in a school environment. Sometimes as providers, they get a little bit nervous if it's going to go home because making sure we get it back can be a challenge sometimes. Not that y'all would ever do that, but sometimes that is a little bit. So they may be a little bit more skittish just to let you take it home, but definitely in a school environment, a therapy clinic, they can work on that for a couple weeks from that standpoint. So, but for power, there is like a mid-wheel drive and a front-wheel drive for chairs. And then also you can kind of look at the base, because a lot of the bases these days can add things over time, or they might start out with them. So for example, I'll show you in a second, but there's like tilt and recline, there's seat lift. You can add those as the diagnosis progresses, or you can have them all at the same time. You can also do speech communication devices, and they can run through the electronics. So you could have it where you could actually answer the phone through the electronics. You can use your speech device through that. So things like that from that standpoint. So there's a lot of things they can do with the powers. There are some basic power chairs, kind of like your scooters and your basically what they call sit and drives, but they usually don't give all those adaptations from that standpoint. So for example, when you would want to switch from a power assist to a powered chair.
So you want to take the whole day into consideration, right? And any of these ADLs and functional skills that we talked about earlier, what you want to consider is how much energy are you expending doing X? And would it be better suited conserving that energy using some kind of device? Like, can the individual walk? Sometimes yes, sometimes no when we're talking about power. Sometimes they can walk a little bit, but they're so fatigued after walking the 20 feet to get into their school classroom that then they don't have enough energy to participate in the lesson. You know, when that's the situation, then my vote as a PT is to drive towards the power option. Obviously, it's a big team decision. You have to involve, you know, not just the PT or OT and the ATP, but you're making sure that the parent and the child or whoever is involved is on board. And when you go this route, you're also needing to factor into it transportation to and from school or wherever.
So most chairs actually have tie-down hooks to them, so they can be transported. Typically schools, and once again, I can't speak for every state, but typically schools have to be able to get the child in the chair to the school, so they can deal with that. So they usually have the buses equipped to be able to transport the chair. Unfortunately, most insurance companies won't help you pay for the vehicle or any type of adaptations from that, so that can be a limiting factor from that standpoint. Plus, you got to be able to get it into the home. So I've been more than once to a house where they just moved and they have like 10 steps going into their house. That becomes very difficult, but there's different things that can be done there as far as a ramp. There's a vertical lift that goes from the outside that can lift up and then kind of go in that way. So there's different ways you can be able to do that. So those are all the things you kind of want to think about when you start looking at it from that standpoint. But don't shy away from power, because a lot of times you can get over those hurdles, or even you may need the power for everything Jen talked about, but they may need it really for school. So I've had some kids that leave the chair at school throughout the week, because when they come home, they can use their manual chair in the home and things like that. So this does have a lot of different options, and you don't have to get all these different options with the chair, but it has seat lift, so it'll allow you to lift up.
To reach like cabinets for cooking or.
Does that? So you can change it. You can also use it for for
Transfers.
Transfers, to be able to do a slide board transfer, or they may need to be able to stand up a little bit easier, so they can lift up and to be able to get out of it a lot easier from that standpoint. Now, just to give you a heads up, Medicare used to not pay for this, but they now just passed where they will pay for seat lifts. So it's still in the early stages, but they will start paying for those. Most insurance companies have started going that route. So you've got tilt, which tilt the whole seat in the back will go back together. Usually there's a headrest. Left mine at home. So it allows you to tilt. You can also do that in conjunction with recline.
Tilt is really good if you're hemodynamically unstable and you have a quick blood pressure change and you need to really quickly get into a position.
So recline, the back just goes back itself from that standpoint. And then we also have the power legs. And same thing, you may not need all these different items because there are pros and cons to like recline. Some people don't use that as much as they use tilt. So it really just depends on what you would need. But if something changes down the road, like if you start out with tilt only with this chair, they could come in and put recline on it later because it's just an actuator and the electronics can already do it. Now, one of the nice functions we have with this chair, if I can get it back up, is we actually have active reach. Just a second. Am I done? Sorry. You what? I was just passing on this. I'm sorry, I talked too much. So active reach allows the chair to tilt forward.
That helps with transfers, getting into and out of the chair.
So it actually will take the chair and go forward like that and help for transfers.
Okay, we have bracing last with Miss Brenda.
Hi, I'm Brenda Sorrells. I'm an orthotist, certified orthotist. Thank you. I've been an orthotist for 25 years. I did lose my voice last weekend, so bear with me. So I prefer to work closely with the physical and occupational therapists. Certainly, the team approach typically gets us the best outcome. When it comes to orthotics, I have the ability to do off-the-shelf and custom. Custom allows us to not only get a just right fit, but allows us to add in specific options that we may want and leave out things we don't want. So the last thing we ever want to do is to overbrace. We want somebody to be able to, we want to be able to allow them to use the function that they currently have, use the range of motion they currently have, and don't ever want to take that away. Sometimes as disease processes progress, then we have to provide more support or possibly limit more range, but we don't ever want to do that before we have to do that. So from an orthotic standpoint, you may need an orthosis for many different reasons. Deformity, loss of muscle strength, bone deformity, fracture. And it's sometimes, especially when it comes to strength deficits, when we're working with therapy, we know specifically, or we get better feedback about what specifically we want to address. Sometimes if I'm meeting somebody in the office and I'm doing an initial evaluation, I don't have the opportunity to get as much feedback or as much information as I do when I'm working with a therapist that sees a family on a weekly basis. Things to consider when we're fabricating any type of orthosis. There's a list up here, so I won't read those to you since we're getting short on time. I'll touch on them briefly. I have a lot of examples of the specific ways that we do manage each of these for so pressure relief today, inside, especially with children, inside of an orthosis, inside of an AFO, for example, we'll use an inner boot. I can make that out of so many different materials. That can help with allergies. It could help especially with bony prominences and help to alleviate some high pressure areas. Temperature. Temperature is a big one, especially in the Carolinas. Back in the day, everybody knows Forrest Gump. We've moved away from those full metal braces to help make them a lot more lightweight. But the other side of that is now we use plastics that aren't breathable. So I have examples up here of a lot of interfaces that we could use, body socks, whether it's for the torso or the lower extremities. And using those socks before putting on a plastic brace can help with moisture and temperature regulation. Decreased sensation. A lot of our pathologies that we work with the patients have issues with decreased sensation. And it's a big one in terms of there's not a lot that we can do when somebody has decreased sensation other than properly educate and give them different ways that they can manage things. If you can't feel something or feel if something's happening, it's going to be extra important that they are visually watching what is happening to avoid areas of high pressure and breakdown. And again, I'm just going to fly through these last few since we're short on time, but I have a lot of again, examples up here. So decreased visual acuity. We want people to, I can help them to better feel maybe where they are in space, give that proprioceptive feedback. And then there's some devices up here that have increased ease of donning and fastening for those that may not be able to see them as well either. One of the biggest reasons that we do use orthotic devices is for energy expenditure. We want to help conserve energy throughout the day for those who are ambulatory. And so sometimes when we have drastic gait deviations, if we can improve alignment and help them to walk more efficiently, that's going to help their overall energy expenditure. And then independent donning and doffing. This is one that a lot of the time OTs will work on in practice, especially in the adult world. And that happens a little less frequently in the pediatric world. But in a perfect setting where you have a good team approach, again, best possible outcome. So sorry I rushed through that, but I know we're short on time.